Hello MT3, as mentioned, we will be discussing your disorders of secondary hemostasis. So again, for you to be able to recall your hemostasis, again, the main components of your hemostasis is your platelets, your blood vessels, and your coagulation and fibrinolytic factors. Anything that would disrupt these three components could have an imbalance with your coagulation and your fibrinolysis, okay? And anything that leads to excessive coagulation is associated with thrombotic disorders, and anything that is excessive to fibrinolysis may lead to bleeding disorders. Again, our components for hemostasis are your vascular wall, your platelets, and your coag factors. Okay na tayo sa mga vascular disorders. And then we have also discussed the different quantity and your qualitative platelet disorders in the last topic. So now, we would now be focusing on the different coagulation factor deficiencies and other regulatory proteins that may affect your secondary hemostasis. So as a recall, again, your secondary hemostasis is composed of your coagulation, and the second one is your fibrinolysis. Huwag kakalimutan si fibrinolysis, guys, ha? Okay. Now, in coagulation, this involves your different coagulation factors and your different proteins that are important in the cascade. Okay? In the coagulation cascade, we have your different pathways. You have your intrinsic pathway, your extrinsic pathway, and your common pathway, which eventually leads to the activation of your fibrinogen into fibrin, which is important in the formation of your clot formation. Okay, now together with your fibrin, you have your FSF or your fibrin stabilizing factor, which is factor 13, which is also activated by your thrombin. This helps to be able to stabilize your fibrin clot. Okay, and then in continuation of your formation of your fibrin clot formation, again, your fibrin is broken down into FPA and FPBs, which are known as your fibrin monomers, which then links together from one another through their different domains and eventually be able to form your fibrin polymers. Okay, these fibrin polymers are linked together through the help of your factor 13, kasi nga siya yung nagsistabilize, and other proteins such as your fibronectin and your alpha-2 antiplasmin. So the end result of your coagulation cascade is the formation of insoluble stable fibrin clot. And then after nag-heal na yung injury natin, it's time for you to be able to dissolve the clot formation that you have produced in the coagulation cascade. For the next step is your fibrinolysis. This starts off with your activation of your plasminogen into plasmin through the help of your activators TPA and your urokinase. Okay, your plasmin is responsible in the degradation of your fibrin monomers and your polymers, which eventually becomes your FDPs and your D-dimers. That's why the levels of your FDPs and your D-dimers are used as an assessment to be able to know the proper function of your fibrinolysis. Let's go over now with your different thrombotic disorders. Okay. Your thrombotic disorders is of course associated with your thrombosis. When we say thrombosis, this is the inappropriate formation of platelet or fibrin clot that may obstruct a blood vessel. This leads or causes to ischemia, which is a blockage to any blood vessels, any tissue, or any muscle, and also leads to necrosis, which is known as your tissue cell death. Your thrombosis is also associated with the term thrombophilia. Thrombophilia is also known as your hypercoagulability. This is a predisposition to thrombosis secondary to congenital or acquired condition. Now, thrombophilia may have its different causes. It may be due to physical chemical or biological events. It may also be due to uncontrolled platelet activation and blood coagulation system activation. And it may also be a deficiency with your regulatory proteins responsible in inhibiting the activation of your coagulation. And lastly, it may also be caused due to uncontrolled suppression of your fibrinolysis. So this table summarizes the factors that can contribute to thrombosis or yung mga causes that may lead to the presence of thrombosis. Okay? Ito yung mga lifestyle, yung mga physical factors such as your age, and then physiologically kapag pregnant ka, you are 3 times to 5 times at risk for thrombosis. And then in the different chemical factors, once you are able to have a different diet, okay, there will also be lipid metabolism imbalance. And then kapag you're also taking oral contraceptives, this can also contribute to thrombosis. Okay, and then other factors, kapag there is traumatic injury to the patient, such as your femoral or tibial fracture surgery, and then other lifestyle, if the patient is smoking, and if there is also the presence of a central venous catheter. Okay, for you to be able to assess the different hemostatic disorders, you have to consider these screening tests. Ito yung mga test na tinitignan nyo para agad nyo malaman if meron siyang bleeding or thrombotic disorders. Okay? And then, ito din yung mga usual na nakikita nyo in your cases. Okay? For example, you have your hemoglobin and hematocrit. Okay? These are usually decreased because some of the hemostatic disorders are associated with anemia or decreased levels of red cells because of chronic bleeding or kapag nako-consume siya in the coagulation. Okay? And then there's also the levels of your reticulocyte count, because when your bone marrow is also associated or dysfunctional in a hemostatic disorder, your bone marrow also compensates for it and thus would have increased or decreased reticulocyte count. Okay? There's also the platelet count, of course, because you have to determine whether if it's a quantitative or a qualitative platelet disorder. Okay? And then you also have your PT and your PTT, your pro time and your partial thromboplastin time. Just remember that your PT and PTT assesses your secondary hemostasis or your coagulation factors. Okay? Your pro time assesses for your extrinsic and your common factor deficiencies, and your your partial thromboplastin time assesses for the intrinsic and your common factors deficiencies. Okay? And then lastly, you have your thrombin time. Thrombin time is used to assess the levels of your fibrinogen or your factor 1. Okay? So you would be able to know whether the patient has hypofibrinogenemia or hyperfibrinogenemia. Let's go over now with your different hereditary coagulopathies. First off are your hemophilias. When we say hemophilia, these are rare blood coagulopathy that is due to deficient coagulation factors. We have 3 classifications of hemophilia. You have your hemophilia A, B, and C. For hemophilia A, this is also known as your classical hemophilia, and the factor deficient is factor 8. Okay, important notes to consider for factor 8 deficiency or classical hemophilia is that it has an inheritance pattern of X-linked recessive. And among the hemophilias, this is the most common type. Next, you have your hemophilia B, which is also known as your Christmas disease. Okay, the factor deficient to this hemophilia is obviously your factor 9. Okay, or your plasma thromboplastin component. Okay, this is similar. It has a similar inheritance pattern with hemophilia A. It also is a X-linked recessive. Last one, you have your hemophilia C, which is also known as your PTA deficiency or your plasma thromboplastin antecedent. Okay, the factor deficient is of course your factor 11. Okay, and then siya lang yun yung iba na inheritance pattern. It has a autosomal recessive inheritance pattern. Its gene is located at chromosome number 4, and among the hemophilias mentioned, this is the mildest form of hemophilia. Okay, so meaning sa hemophilia C, konti lang yung bleeding tendencies. Okay, unlike with the other two, si hemophilia A at si B. So, yan. So, just a recall with your, when we say X-linked recessive inheritance, this is where your mutated gene is usually found at the X chromosome. So, if your mother is a carrier of your hemophilia, there is a 50% chance that you would have one affected son and a 50% chance of a carrier daughter. Remember guys that since the gene is found at the X chromosome, basta may isang X chromosome lang na affected tapos namana ng male, then automatically it would be able to manifest the hemophilia. Unlike with females, since dalawa yung ating X chromosomes, pag isa lang yung affected, magiging carrier lang siya. Kailangan both X chromosomes should be mutated or affected before manifest ni patient, ni daughter, yung hemophilia. Pero since it's X-linked recessive, usually females are just carriers and the males are considered homozygous carriers or affected genes of hemophilia. So, kindly please remember all the laboratory test results associated to the different hemophilias because that's the only way for you to be able to differentiate these three aside from dun sa deficient factor nila. Okay? Yung specific factor assays natin, yung nasa baba, si factor 8, von Willebrand factor assays, your factor 9 assays, and your factor 11 assays. Of course, kapag may specific assays na kayo, malalaman nyo agad anong hemophilia siya. Is it A, B, or C? However, if in the presence of there is no assays that you could be able to perform, then it's time for you to be able to check the different or the general laboratory tests that we perform in both the primary and secondary hemostasis. Ayun. So, anong mapapansin nyo? From bleeding time down to the fibrinogen levels, itong part na to, all the results for hemophilia A, B, and C are just the same. Normal, normal, normal. Ayan. Increase, increase, increase. Ayan. No? So, pag ito lang, yung ginagamit yung laboratory test, mahirap i-determine kung anong specific type of hemophilia. Pero usually, pag ganyan yung mga results, automatically, it is associated with hemophilia na. Okay, hindi nyo lang ma-determine anong type. Okay, and para ma-determine nyo yung type, dun pa lang kayo magpa-perform ng specific assays. Okay, si factor 8 assay, factor 9 assay, tsaka si factor 11 assay. Other hereditary coagulopathies are your Oren's disease. Your Oren's disease is also known as a parahemophilia. So, meaning to say, parang hemophilia siya. It looks like a hemophilia, pero hindi siya classified as a type of hemophilia. Okay? It was just named as such kasi the bleeding tendencies seen in Oren's disease are similar with hemophilias. Okay? It was discovered by Paul Oren in the year 1943. So, in Oren's disease, there is a deficiency or absence of your coagulation factor 5 or your proaxillary. Its inheritance pattern is autosomal recessive. Next, you have your Hageman trait. From the name itself, Hageman. So, ang deficient factor natin ay si factor 12. Okay? It's usually located at chromosome 5. Okay? And inheritance pattern is autosomal recessive. Okay? Your factor 12 deficiency is not associated with severe hemorrhagic symptoms. Okay? Even after trauma, surgery, and childbirth. Kasi if you can recall, diba, si factor 12, nandun lang siya sa pinakataas ng ating intrinsic pathway. Okay? So, if affected siya, hindi siya masyado mag-lead to bleeding disorders kasi eventually you still have your other activators, your high molecular weight kinogen and your kallikrein, which would also activate your cascade. So, in summary, these are your rare congenital single-factor deficiencies. So, for the first three, see, fibrinogenemia, hypofibrinogenemia, and dysfibrinogenemia, these are associated with coag factor 1. When we say fibrinogenemia, wala talagang levels of fibrinogen. When we say hypofibrinogenemia, the fibrinogen assay is less than 100 milligrams per deciliter. And when we say this fibrinogenemia, similar with the levels of hypofibrinogenemia, it's just that when we say this fibrinogenemia, nagkakaroon ng decreased fibrinogen assay or activity because your fibrinogen is dysfunctional. Okay, it's dysfunctional. Okay, next, prothrombin deficiency. This is coagulation factor 2. And then factor 5, si Oren's disease. Factor 7 deficiency. This is your associated with extrinsic pathway. Your factor 10, si Stewart-Prower deficiency. Your 11, si hemophilia C. Hemo C. And then factor 13 deficiency, I see FSF deficiency or your fibrin stabilizing factor deficiency. Let's go over now with your acquired coagulopathies. Okay? The first one is your vitamin K deficiency. As mentioned in our previous discussion, your vitamin K is an important fat-soluble vitamin, important in the post-translational processing of your prothrombin groups and your other regulatory proteins. Ang kailangan nila ay si carboxylated protein through the help of your enzyme, gamma-glutamyl carboxylase. Okay? The vitamin K is named as K kasi it came from the word K na coagulation. I think German ata to. Kaso, hindi na nila magamit yung letter C kasi may vitamin C na, diba? So, ginawa na lang nilang vitamin K. Si vitamin K. Okay? Now, conditions that may lead to deficient vitamin K may be lead to HDN. This is your hemorrhagic disease of the newborn. Okay? It may also lead to biliary obstruction, malabsorption of vitamin K, nutritional deficiencies, and the use of your drugs such as your oral anticoagulants such as your warfarin and other broad-spectrum antibiotics. Okay? Your oral anticoagulants inhibits your processing of your vitamin K. So if you use or if there would be overdosage of the use of warfarin, then you won't be able to produce your vitamin K dependent carboxylase, si gamma glutamyl carboxylase, and therefore you cannot be able to produce your prothrombin groups 2, 7, 9 at saka C, 10, and your other regulatory proteins such as your protein C, S, tsaka C, Z. Next, we have your liver disease. Okay? Now, different liver diseases such as your cirrhosis due to usage of drugs and alcoholism, hepatitis, liver cancer, and chronic liver disease. Okay? Now, these disorders are associated to leading to coagulopathy because of the following reasons. Okay? Kasi nga, di ba si liver, your liver synthesizes most of your clotting factors like your fibrinogen, your prothrombin, your factor 5, 7, 9, 10, and 11. So, if compromised or there would be disorders involving or disruption in your liver, then your liver would not be able to synthesize these coagulation factors and therefore would affect your hemostasis. Okay? Aside from that one, since your liver is also affected with these disorders, there will also be a increased clotting risk or your thrombosis because your anticoagulant proteins such as your protein C, S, and your antithrombin, which are produced in the liver, would be also decreased. Okay? These are responsible in the stoppage of your coagulation cascade. Diba guys? So, if nawawala si protein S, C, at saka si antithrombin, kasi hindi siya napoproduce ng liver, kasi meron kang sakit sa liver, then therefore, it would lead to thrombosis or increased clotting risk. So, again, In summary, for liver diseases, basta na-compromise yung ating liver, there would be chronic damage. You won't be able to produce now your different coagulation factors and your different regulatory proteins. Okay? So once you cannot be able to produce these coag factors and regulatory proteins, this would eventually affect your hemostasis and usually leads to thrombosis or thrombotic disorders. Okay, dito na tayo kay DIC. DIC, again, stands for Disseminated Intravascular Coagulation. Okay, ewan ko na lang kung hindi nyo pa ma-memorize yung meaning ni DIC, kakaulit sa kanya. Okay, now in DIC, guys, there is the activation of your intravascular coagulation and also your endothelial damage. In endothelial damage, it would eventually lead to microvascular thrombosis. Okay, meron kayong mga presence ng small clots. Okay, and then also a red cell anomaly associated with it, which is your schistocytes. Okay, now once you have these small clots and schistocytes, these eventually flows in your circulation and might affect a blockage in your different organs, which eventually leads to multi-organ ischemia or failure. Okay. Now, on the other hand, there is also the activation of your intravascular coagulation. So, na-activate si coagulation cascade, which would lead to the following. There would be the platelet consumption, kaya magkakaroon ng thrombocytopenia or decreased platelet. Kasi lagi silang nag-a-attach dun sa vessel na may injury. Kasi lagi silang na-activate, lagi silang nag-a-adhere, lagi silang nag-a-aggregate. Okay. Aside from that one, there would also be the consumption of your coagulation factors. Kasi nga, once there is a presence of a tissue damage or a presence of your negative surface particles such as your collagen due to the vessel injury, therefore your coagulation cascade would be activated, and thus your coag factors would be continuously activated and consumed in the injury, which eventually leads to increased pro-time and partial thromboplastin time. And then lastly, there would also be the activation or increased levels of your fibrinolytic system. Okay, so it would always be activated kasi nga, kapag meron siyang nadidetect na clot, ang natural response niya is to be able to dissolve this clot. Okay, now since there would be increased fibrinolytic system or increased dissolution of your fibrin, there would also be the increased levels of your FDPs and your D-dimers. Okay, kaya si D-dimers, guys, kapag increase ang levels niya, that means there is increased activity with your fibrinolytic system. Okay, now these three laboratory assessments are important for you to be able to diagnose your DIC. Okay, tatandaan yan. And again, your DIC is characterized by excess thrombin formation. Okay, dahil continuous activation ng coagulation cascade. There's also the excess conversion of your fibrinogen to fibrin, same, kasi na-activate si coagulation cascade, and also the consumption of your platelets kasi they continuously activates themselves because of the intravascular injury present. Okay, ayan, tatandaan yan, ha? Okay, now your DIC can be in different alternative forms. Okay, it could either be a DIC with a activated clotting and at the same time lysis. So, meron siyang clotting, meron din siyang activated na lysis. So, activated both si coagulation cascade niya at saka si fibrinolytic system niya. Okay, nagkakaroon ng thrombosis, nagkakaroon ng bleeding. Okay, it can also be a DIC wherein your clotting is predominated with little to no lysis. So, meron lang siyang continuous activation ng coagulation cascade. Tapos, yung na-form na fibrin clot, hindi siya nalalyze, which leads to thrombosis. Tama? Yes. Okay. And then lastly, your DIC may also be a primary fibrinogenolysis wherein your cascade is being activated and thus your coag factors are consumed, and then mas mabilis yung lysis niya or predominated si fibrinolysis, which leads to bleeding naman. Okay. Now, you have your different other names or alternative names for DIC. It may also be known as a consumption coagulopathy because from the name itself, nakokonsume ang ating mga coag factors at saka si platelets, which leads to either thrombosis or bleeding, or pwedeng both. Okay? Another name associated with DIC is your defibrillation syndrome because of the increased breakdown of your fibrin kasi nga na-activate si ating coagulation cascade. So, lagi kayong nakaka-form ng fibrin. And eventually, this fibrin is laging nabe-breakdown ng ating fibrinolytic system. Okay? Another name is your systemic intravascular coagulation, which emphasizes that this disorder is affecting the entire vascular system and a multi-organ functional system. Another name is your acquired coagulopathy. This is named as such kasi nga si DIC is acquired and becomes a secondary condition. Tatandaan guys, si DIC would never be a primary condition of a patient. Magkakaroon siya ng DIC secondary to a primary condition niya. Okay, so nagiging lang siya, nagiging complication si DIC ng isang pasyenteng may sakit na talaga. Okay? And then lastly, it may also be associated or named to as microangiopathic hemostatic disorder because of the formation of the small clots in the blood vessels. So, kindly remember guys, the significant laboratory findings for you to be able to determine the presence of DIC. First off, ay syempre, in PBS, you would be able to see the presence of your schistocytes or your fragmented RBCs. Platelet count and fibrinogen levels are decreased. Your thrombin time and your reptilase time are prolonged, same as with your PT and your PPP. Okay? There would also be the presence of your FSP or your fibrin split products or your FDPs, guys. Okay? At saka si D-dimers. Okay? Kaya increase siya lagi or present. Okay? Ito pala siya. Bayan. Okay? Now, ito yung sinasabi nating alternative forms ni DIC. Either both, meron siyang activated clotting and lysis. Pwedeng clotting lang siya or lysis. Okay? Tatandaan, ang increased D-dimer levels lang ay associated with both the clotting and the lysis. Kasi kung sa clotting, guys, kung negative, it would be negative kasi walang nalalyze na fibrin polymers. Okay? So, walang na-form na FDPs at saka D-dimers. Okay? And then, in the lysis, it's also negative kasi your coag factors are consumed. However, you are not able to form your fibrin or your clot formation. So, wala din siyang nalalyze na FDPs and D-dimers. Next is we have your deep vein thrombosis or your DVT. This occurs when a blood clot or a thrombus forms in one or more of the deep veins of the body. This is usually associated with the lower limbics at saka sa arms ng mga patients natin. Okay? Now, your DVT is part of the pathological entity known as your venous thromboembolism or VTE. Your VTE is composed of your DVT, si deep vein thrombosis, at saka si pulmonary embolism. Kasi nga nagtatravel yung thrombus or blood clot in the circulation. So, either they stay in the deep veins ng patient or in the, it could travel in the lungs of the patient, which eventually leads to pulmonary embolism. Okay? Now, for you to be able to determine venous thromboembolism, it should follow your virtuous triad. Okay? There should be the presence of your endothelial damage, hypercoagulability, and stasis or immobilization. Next is we have your circulating anticoagulants. These are acquired inhibitors of clotting proteins. So from the name itself, once you have these circulating anticoagulants, they would inhibit your coagulation factors. These are abnormal endogenous components of blood that inhibit the coagulation of normal blood. They may act at virtually at any stage in the process of coagulation. Okay? Now you have your different circulating anticoagulants. This could either be a specific inhibitor, so meaning they are antibodies specific to your coag factors, such as your factor 1, 5, 8, 9, 12, and 13, and also with von Willebrand factor. It could also be in the presence of anti-phospholipid antibodies, wherein these protein complexes adhere to your phospholipids, which are important also in your hemostasis. This could either be a lupus inhibitor anticoagulant, anti-cardiolipin antibodies, or anti-beta glycoprotein 1. And then, pwede din silang maging in the form of antithrombin, FDP, and other abnormal proteins. And I think that ends our discussion for the secondary hemostasis disorders. Other thrombotic disorders that you have to consider and read them in your books: your protein C and S deficiency, your heparin-induced thrombocytopenia, and your antithrombin deficiency. These are just reading assignments kasi etong tatlong to guys, pare-pareho lang yung mechanism nila as to why it leads to thrombotic disorders, because they are deficient with the regulatory proteins. Tapos dito, meron kayong presence or intake of heparin. And then also this one, you are deficient with the antithrombin or a regulatory protein also. So, madali lang silang basahin. Okay, guys? And then, other antithrombotic therapies and their laboratory assessment. Specifically, I think this is a specific chapter in RODAX. Okay? Kindly read the function of your coumadin, your unfractionated heparin, and your low molecular weight heparin, your oral anticoagulants, and your different antiplatelet therapies. So these are the references for this topic. So thank you guys for listening.